It's what makes us us.
It's what makes us us. It's what makes us well, us.
That's the one that stings the most. I can't be the only person that's gone through this.
It's just the music of us.
In every note,
Every lyric.
the music of life unfolds into a symphony that's
Uniquely ours. Each year, nearly 50 million Americans suffer from
adverse drug events, the fourth leading cause of death in the U.S. This stage isn't just about the perfect chords. Every note tells a part of our story.
If something feels off,
You're not alone. It's what
makes us us.
Visit fourthcause.org to learn more. It's what makes us us.
All right, good afternoon and welcome to our National Adverse Drug Event Awareness Day webinar. I'm Sarah Rogers, co-founder and president of the American Society of Pharmacovigilance, and it's an honor to kick off today's important conversation. We're here because adverse drug events are one of the most preventable yet under-recognized public health threats in the US and globally. Every year, adverse drug events result in over 1 million emergency department visits and hundreds of thousands of hospitalizations. Behind every number is a patient, a family, a story, and an opportunity to do better. I'm excited to be co-hosting this webinar with Ben Brown. Ben is ASP's co-founder and executive director. The American Society of Pharmacovigilance was founded in 2018 with a clear purpose: to prevent adverse drug events through advocacy, education, and research. We are a growing multidisciplinary community, uniting clinicians, researchers, patients, and policymakers to work across silos and tackle preventative harm. Our vision is a healthcare system where medication safety is prioritized at every level and preventable harm is no longer overlooked. Through national initiatives and awareness efforts like today's event, we're driving systemic change and empowering others to do the same. But before we dive into the solutions, it's important to start with a shared understanding. An adverse drug event, or ADE, refers to any harm a patient experiences due to a medication, whether that harm results from a prescribing error, a known side effect, a drug interaction, or a failure to monitor. In this figure, all of the blue areas represent adverse drug events, instances where a patient is harmed by a medication. The darkest blue area in the center is where you can see adverse drug reactions. These are unwanted effects that happen even when everything is done correctly. Often, adverse drug reactions are called side effects. On the left, you can see medication errors. These are mistakes like giving the wrong drug or dose. The vast majority of adverse drug events are preventable, and that's why we're here today, to explore systems, data, and how people can work together to reduce these risks and keep patients safer. National Adverse Drug Event Awareness Day is held on March 24th each year and was launched by the American Society of Pharmacovigilance as a call to action, a moment each year to pause and reflect on the preventable harm caused by medications and to recommit ourselves to doing better. It's more than a campaign, it's a movement. A day to honor those who have been impacted by medication harm, a day to spotlight the science, share stories, and support the systemic changes needed to make medication use safer for everyone. This day unites us, whether you're a clinician on the front lines, a researcher in the lab, a policymaker shaping safety standards, or a patient advocating for change. Our latest press release that went out this morning reflects a sobering truth. Adverse drug events have now become the third leading cause of death in the US, claiming more than 250,000 lives a year. This is not just a statistic, it's a public health emergency. That's why ASP has rebranded its flagship awareness initiative as the Third Cause campaign. With this rebrand comes a bold national action plan. First, we're assembling a national medication safety task force to align leadership and set priorities. Second, we're investing in education and training because frontline providers must be prepared to identify and prevent ADEs. Third, we know that precision medicine, especially pharmacogenomics, can reduce risks when used wisely. And finally, we believe in the power of public engagement. Through the new Third Cause campaign, we want to give every patient and caregiver a platform and the tools to demand safer medication use. Before we dive into today's presentations, I want to center us on the goal for this webinar. We're not just here to raise awareness about adverse drug events, we're here to focus on actionable solutions. Every speaker you'll hear from today brings a different lens, clinical, personal, policy, or technology, but they all share a common purpose, helping us to identify real-world, practical ways to prevent medication-related harm. From improving informed consent and deprescribing practices to leveraging pharmacogenomic tools and patient reporting systems, this webinar is about sharing strategies we can apply, systems we can improve, and voices we need to elevate to make meaningful progress. Whether you're a provider, policymaker, patient advocate, or researcher, there's a role for you in preventing ADEs, and we hope you'll leave today with at least one concrete idea or action step to bring back to your work. If you have any questions during the presentations, please type them into the chat. We will save all questions until the end of all of the presentations. We also wanted to let you know that the content presented during this webinar is intended for educational and informational purposes only. It's not intended to provide medical advice, establish standard of care, or replace judgment of qualified healthcare professionals. Speakers are sharing their perspectives, experiences, and strategies to help reduce preventable adverse drug events and improve medication safety. Participants should consult appropriate clinical guidelines and licensed providers before making medical decisions. So with that, I'll turn it over to Ben to introduce our first speaker.
Hi, good afternoon, everybody. We're glad that you're here, and thank you for coming together with us to educate, equip, and pull back the curtain on more aspects of ADEs, hear from different patients, their stories and advocates, in an effort to inform and educate you so you can leave today, if it's only with even one idea on something you could do different or something you could share with a loved one in your family, that would be tremendous. It's my pleasure to introduce our first speaker, Michelle Sarkisian. She spent 30 years at Merit's, where she was a senior executive leading in the hospitality sector. Since retiring, Michelle has been serving on boards, including healthydining.biz and hnri.org. She's an activist in anti-trafficking, medical freedom, and legislation, among other priorities. Please welcome Michelle.
Thank you, Sarah, Jacob, and Ben. You and your colleagues are really doing important work. Sarah's described the avalanche of adversities and medical problems from FDA-approved drugs, and we have had very clearly an epidemic of adversities. As Sarah mentioned, no one is suggesting that all drugs are bad, nor is anyone here providing medical advice, but it's become increasingly clear that the system is broken relative to healthcare's long-standing Hippocratic oath of do no harm. In fact, the epidemic of adversities is where it is because each stage, from quick and loose assessments to actually reporting harm, is flawed. Imagine a plane load of passengers crashing every day in America. NTSB would bring air travel to a complete halt until root causes were determined and they were corrected. Yet here in America, that is happening every day with a medical problem or adversity. We in America have about 5% of the world's population, yet are taking over 50% of prescription drugs. Let that sink in for a minute. We have record levels of suicides, especially among those taking black box prescription drugs. And that's just one of the side effects of black box drugs. Black box drugs are those with severe enough side effects to warrant a black label warning on the drug packaging, much like the Surgeon General put the required cigarette packages to warn of cancer risks decades ago. America has record suicides, homicides, violence, hallucinations, dissociation, all listed as potential side effects and risks of black box labeled prescription psychotropics. Many recognized names like Prozac, Zoloft, Adderall, Ritalin, Xanax, Paxil, and many more are commonly prescribed for children based on observations and surveys for ADHD, depression, anxiety, and gender dysphoria. Those mental health prescriptions are order of magnitude higher in America than anywhere in the world. By the way, America's drug volume is also very high by comparison to other countries when it comes to weight loss, cholesterol, and many other maladies. We are simply overprescribed. When it comes to children, parents are becoming more vocal every day that they do not want their children assessed, surveyed, or mandated regarding any medical issue at school. In fact, it can violate constitutional parental rights to do so. That violation resulted in a successful lawsuit just last week in North Carolina, by the way. An excellent resource to understand and know how to opt out of school practices that violate your parental rights is Kelly Himes Brawley's book, Laws, Rules, and Rights. I think Jacob might put that up on the screen. It's a great book. And in fact, she covers all 50 states in that book. So before we get into the solutions and resources that Sarah mentioned, Bob Schwartz will demonstrate the current system's failures with his very personal story. Bob is an adverse drug event impairment survivor. His journey began 21 years ago when he was a top-performing telecom executive, and his entire life changed 5 days into a commonly prescribed prescription drug.
Ladies and gentlemen, allow me to introduce Bob. As Michelle was saying, Bob Schwartz is a drug impairment expert and survivor of a near psychotropic medication-based adverse event, which inspired him to start a mission-based 501c3 called A Better Bob, where he is executive director. He is also the executive producer of a short documentary film about his tragedy and experience, If I Had Known the RX Risks. Bob, thank you.
Ben, thanks so much. Michelle, thank you so much for that introduction. First, before I start, I want to thank the ASP, Sarah, Jacob, and all the members of the organization for creating this awareness recognition day on March 24th. This is the 4th year that you guys have launched programs like this, and I can only see that it's only going to keep getting greater and greater each year. March 24th is a very significant day for me because 21 years ago, that's the day I had my adverse event, and now it is the day of recognition. Let's dive into this story. In March of 2004, I went to a simple doctor's appointment that I had for chronic back illness. Normal appointment, the doctor prescribed me some muscle relaxers for my back. And in the last 10 minutes of the appointment, doctor asked, "What else can I do for you?" I was going through some focusing issues at work, and I just wasn't focusing too well. Found out later that was probably due to my chronic back pain. At that moment, my doctor looked at me and off-label looked at me and just said, maybe that could be ADHD. And without much conversation, he decided to say, let's see if we can, fix that with some medication. And at the time, he recommended a drug called Concerta. Didn't know much about the drug at the time, but it's a stimulant-based ADHD medicine. At that moment, he asked me how much I weighed, and I gave him my weight. which at that moment he put me on 54 milligrams of the drug Concerta. At the time, and still today, that's the highest dosage that you can give. You know what? Trusted my doctor. We had a very good fiduciary relationship. So 2 weeks later, I filled the prescription and started taking the medication. After 5 days of being in the it, at my desk at my office, I was overwhelmed with the feelings of that somebody was after me, somebody was going to hurt me, and I ran out of my office building, slipping in and out of consciousness. I still remember that day where I went through the revolving doors and I had to stop and turn around. And looking back at what I had just done, I was just kind of like, thought to myself, why did I just do that? And unbeknownst to me, I was suffering an acute psychosis. And if anybody needs a visual of what an acute psychosis is, the best example I can give you is it's from the movie A Beautiful Mind with Russell Crowe, and that is when life has never been the same after that. Basically, I went home. I told my wife at the time that something terribly was wrong. Something was wrong with my mind. I was experiencing something that was out of the norm for me. It was very difficult to understand what was going on. I think it's important to share with you at this moment some of the side effects that happened over the next 90 days and persistent with the years to follow, and of this adverse event that I had suffered. The first one is complete social withdrawal and personality change that I went through. I was still experiencing dysfunctional state of paranoia, severe insomnia, could not sleep whatsoever, severe stomach pain, which lasted for a number of years, at least 5 years. And what's interesting, through the course of what took place, happened to me, I found out many years later, this is what they call leaky gut. And anybody that has severe stomach pain, it knows that this is a very difficult situation to go through. The next one I experienced was severe headaches, muscle twitching all over my body, hypertension, heart palpitations, severe thought disorder and faulty thinking, depression, severe depression. But the long-term effects that I started experiencing was cognitive impairment, intuitive impairment, and a lot of delay with that, mathematical delay, which really impacted my career, or my ability to work and provide for my family. I had suffered many years later through diagnoses that I had suffered a cognitive impairment because of neurological damage, which led to PTSD. This would led to suicidal thoughts over the last years that I've been going through these experiences. With that comes rants, rages, and revengeful thoughts along the way. And what's really devastating about what took place here is that in the course of this whole horrific tragedy, I lost my family. I lost my career, and I lost my reputation. And that was still hurts today as far as trying to make sense of what took place and what happened. But the purpose of my presentation today is to really explain to you how broken the system is, because back in 2004, um, cognitive impairment and PTSD were whispered words. I mean, if you think about the CTE concussion crisis, that wasn't even on the radar until 2009. So, I was very much, telling people from the very beginning that this was the worst thing that had ever happened to me, and it was not being addressed or taken. I don't know if taken serious enough, as far as it almost felt like I was being gaslighted by what happened to me, or I'm not trying hard enough to get better. And I think it's important to let you know the how broken the system is when I share with you here the systemic failure that took place when I was trying to get help for what had happened to me. Of course, I reached out to my doctor, who who basically ended up 2 years later firing me and telling me to come pick up my folder, and that's well documented in my website, risk.com. If you go to my website and look at the documentary film that we did, and it's laid out from there from A to Z. I also immediately reached out to Johnson and Johnson. That was in May of 2004, after the psychosis has happened, and they failed to contact me and reach out to me, and so I kept going to try to find help for what had happened to me. My next step was to reach out to the FDA and report the adverse event. At that moment, basically it felt like it went down a rabbit hole. No follow up, no nothing. And then I reached out to the MedWatch system, which is a government back adverse event system, which should have triggered at least some kind of help to come and see what I was experiencing at the time. No replies from any of those organizations. I reached out to the Georgia Medical Board at least 3 times to get help and support. Went back to the FDA and to reach out to find out about criminal investigations as far as what happened, because we found out later through our research is that they, through the Concerta manual and handbook that they have, is that you're only supposed to start Concerta at 18 milligrams for first time users, because I had never been diagnosed with any psychological problems up to this point. So it was again just a very horrific experience. I had moved on to HHS and the help with asking them for their help in regards to what had happened to me. Reached out to the Attorney General of Georgia at least 2 to 3 times. In fact, I even went as far as going to the FBI in March of 2020 to kind of explain my story and talk about the dangers of SSRIs. I even went to 2 senators as a whistleblower on the drug Concerta. They acknowledged me, but they had taken no action. I had reached out to over 30 attorneys asking for help. I've gone to numerous media news outlets asking them for help or trying to explain the story. And again, it's a very difficult story to explain. And that's why back during the pandemic, I made the decision to go unconventional and do a 30-minute short documentary film, which won a Telly Award out in New York for Best Documentary. And it lays out what I had gone through, being an impairment adverse event survivor for the last 21 years. And again, the whole purpose of what I'm trying to do in the aftermath of everything that's happened here is I don't want this ever to happen to any other person or anybody else's family. And this is unspeakable hardship. And the whole purpose of my organization is to bring awareness, caution, and accountability to the SSRI marketplace, better informed consent, and with the help of organizations like ASP, I know we're on the right track of getting this done. So again, if you would like more information, or if this something similar has happened to you with an adverse event, please, you can see in my name title that you can go to risk. That's rxisks.com, and you can go on there, learn more about my story, more about SSRIs, and you can even submit your story. And again, thank you, ASP, for letting me share this story today.
Thank you, Bob. What a story. Up next, we have one of my dear friends and colleagues, Christine Ashcraft. Christine has worked in the field of pharmacogenomics since 2000 and was named one of the 25 leading global voices in precision medicine. She is the founder and president of UScript, an award-winning clinical decision support tool that has integrated PGX-guided personalized prescribing into the clinical workflow for over a decade. Please welcome Christine.
Thanks so much, Ben. This is Michael. He died of an overdose because he had an untested pharmacogenetic variation that caused his antidepressant to build up to deadly levels in his body. I first heard his story 25 years ago and have dedicated my life and career to ending avoidable adverse drug events like Michael's. Pharmacogenomics is an underutilized tool in achieving this mission. Quite simply, pharmacogenomics, or PGX, looks at a person's DNA to determine if they need a lower dose, a higher dose, or a different medication altogether. It's compatibility testing for many, but not all, medications used to treat many conditions. Over 350,000 Americans will die this year from adverse drug events. That's more U.S. deaths in 1 year than the total combat deaths in any war the U.S. was in. Over 5 full 737s every day. And even that is likely an underestimation because grandma's fall and broken hip caused by the dizziness from her beta blocker dose being too high that quickly led to her demise is not counted as an ADE. The teenager who committed suicide after weeks on a medication known to elevate suicidal risk for patients with their genetics, not counted as an ADE. The patient unintentionally given twice the dose of 5-FU for their genetics, leading to severe toxicity and death from a chemotherapy meant to prevent cancer recurrence after successful treatment, not counted as an ADE, typically marked as cardiac failure, the final impact of that ADE. And even if they do not cause harm, half of the medications we prescribed do not work as intended and are therefore wasted therapies, ranging from 38% of antidepressants to 3/4 of cancer medications. PGX is not the only reason for treatment failure, but it is a major reason. The personal cost is dire, but the financial cost is also staggering. As of 2016, we spent $528 billion in the US on non-optimized medications. That's more than the drugs themselves or any major chronic disease. And the more medications a patient is taking, the more likely they are to have an issue. Over 40 million Americans now take over 5 medications every day. And with the aging baby boomers, the silver tsunami, that's expected to double by 2040, meaning it's already bad and it's about to get a lot worse. Historically, we have only flagged for drug-drug interactions, even though the FDA has stated drug-gene interactions should be considered the equivalent for years in drug development guidance. To understand why this problem is so large, I'm going to give you a quick lesson in drug metabolism. Most drugs we take are processed by enzymes in the liver. Think of them like highways. We treat every patient as if they have 2 lanes of these drug metabolizing highways that process medication. But genetically, some patients have 1 lane, 0 lanes, or 3 or more lanes. In fact, more than 99% of us have PGX variations, so not the expected 2 lanes, leading to drug or dose change guidance for 10 medications on average. And it's not just the genes. Drugs, herbals, over-the-counters, foods like grapefruit juice send signals to our bodies to close lanes, open lanes, or just take up all or part of an available liver highway by themselves. The good news is we have clinical decision support tools that make it easy to pick safer drugs and doses, just like that traffic app on your phone reroutes us when there are accidents or road closures. They say the definition of insanity is doing things the same way and expecting different results. So how can we make medication safer? PGX cannot solve this epidemic, but it could help significantly. One large study of pharmacogenetic panel testing in several thousand patients in Europe showed a 30% reduction in clinically significant adverse drug events in just 12 weeks. Similar impact here could save lives, reduce harm, and save over $150 billion annually. One model suggested pharmacogenetic panel testing could reduce death by 10.6%. Combining this with a pharmacist-provided comprehensive medication review would incur a low lifetime cost of $450, averting 106 deaths per 1,000 deaths. Comparatively, other preventative measures such as mammograms for breast cancer, low-dose CT scans for lung cancer, and colonoscopies for colon cancer all cost more to prevent fewer deaths. So why are they considered the standard of care, while PGX panel testing is not, when all are worthwhile preventative interventions that have likely saved the lives of people you care about? Unfortunately, most doctors didn't learn about genetics, including PGX, in school. You need to educate yourself about PGX and ask doctors to test you or loved ones when appropriate, or order yourself if you're a provider. If you head to uscript.com/talktodoctor, TALKTODR, there are resources to help, including a flyer of medications impacted by genetics, according to the FDA or CPIC, the guidelines body for pharmacogenetics. If a patient is on one of the medications on the list, or a doctor is considering prescribing one, and they would change drugs or doses based on the results, Medicare will cover testing. And thanks to the efforts of the American Cancer Society Cancer Action Network, Medicaid and commercial insurance is aligning with this evidence-based Medicare coverage in 20 states and growing. Head to fightcancer.org to see how you can support efforts in your state. We need to educate healthcare providers about PGX and how it can help reduce adverse drug events. We need to make it easy for them to know when to test and how to act on it, leveraging technology that has existed for years. We need to update adverse drug event reporting systems that have not been improved since the cassette tape was our main music format. That's why we need your help, driving support of bipartisan legislation, the Right Drug Dose Now Act, reintroduced today by Swalwell and Crenshaw. Ask your congressional representatives to join as sponsors of the bill. Learn more at fourthcause.org/RightAct. During this 1-hour webinar, 40 Americans will lose their life to adverse drug events, many avoidable. It is time for all of us to take a stand. Please take action today. Safer medication management begins with you.
Thank you, Christine. Up next, we have Dr. Lisa McCarthy. She is a pharmacist researcher at Deprescribing.org. Dr. McCarthy is also an associate professor with the University of Toronto's Leslie Dan Faculty of Pharmacy and Department of Family and Community Medicine. She holds appointments with the Institute for Better Health at Trillium Health Partners, Bruyere Research Institute, the Women's College Research Institute, and the University of Waterloo. Please welcome Lisa.
Just making sure you can see the slide deck, okay? Everybody good? Excellent. Okay, hi everybody. I am, as you said, Lisa McCarthy from the University of Toronto and Deprescribing.org in Canada. And my mission is really to make sure that the people that I care for receive the medicines they need, no less and no more. Now, at Deprescribing.org, what we do is develop evidence-based resources that help health professionals and the public partner together to make decisions about when and how to reduce or stop medicines safely. Deprescribing focuses on medicines that might be causing harm or are no longer of benefit. Thanks to ASP for hosting today, and I'm really excited to share more about prescribing cascades and how they connect ADRs with deprescribing. Now, prescribing cascades are something that happen every day, but most people don't recognize them. They begin when an adverse drug reaction occurs and a second drug is prescribed to manage it. This often happens because the new symptom or medical condition is not recognized as related to that first drug. People then receive a new diagnosis and then typically more medications or interventions to manage that condition. They're an important consequence of adverse drug reactions. Now let's dive deeper. Why don't people recognize side effects? Well, a key contributor is time. Think about a classic example where someone develops a skin reaction within hours or days of starting a new medicine. In those cases, the reaction is often typically linked by patients and the prescriber. But there's lots of other adverse reactions that take time to develop. One example is here on the slide, where levodopa is prescribed to treat Parkinsonism induced by metoclopramide. Another one I see in my practice often is with older adults who take and tolerate metformin for diabetes for many years, but then end up using loperamide for diarrhea. This happens when their kidneys no longer work as well, which changes how metformin is handled by the body. And when we reduce doses or stop metformin, the diarrhea resolves. Now, there's more I could say from my research about why and how cascades happen in practice, but let's get to a few more examples. These come from a study we did called Think Cascades. And here we narrow down a list of 140 possible cascades to 9 that international experts considered clinically important for older adults. Now, we're still learning about how many cascades there really are. Data mining studies are saying more than 300 targets. Published studies that we have with reviews say somewhere between 150 and 200. When you look at a list like this, you'll see that cascades are everywhere. They can occur with prescription, over-the-counter, natural health products, and over other substances. Second, some of the side effects you can see in the middle column are very common. So part of the challenge is that prescribers have a lot of possibilities when they're working these up in practice. Finally, it's really easy for someone to experience more than one cascade or to experience a sign or symptom that could be caused by more than one of their medications. Speaking of more than one cascade, in the real world, they rarely happen alone. This example is from a real patient. Now, for the clinicians in the audience, you'll appreciate that putting this together required a ton of detective work. Here, a prescribing cascade became a prescribing web. In terms of harms, this is another area where we're learning. So far, cascades have been associated with increased risks for emergency department visits and hospital admissions, as well as decreases in physical functioning, which has important impacts for quality of life. Also, by virtue of adding more medicines to someone's list, they contribute to polypharmacy or medication overload with its own consequences. What can we do about cascades? Well, my first 2 calls to action can help avoid them. First, own your medication list. Write down why you take medicines and ask how long you should take something before it gets revisited. And remember the medicines you don't tolerate. In Canada, we have studies that have shown that 1 in 3 adverse drug events is a repeat situation where people get re-exposed to something they didn't tolerate in the past. Second, health professionals and the public, all of us need to ask, could this thing that I'm experiencing, sign, a symptom, a new medical condition, be caused by a drug? This is key, especially when your clinical status is changing. Now, these actions alone will undo cascades that have already happened. So third, to confirm a cascade and undo it, we may need to try deprescribing. In practice, I've seen clinicians feel stuck when a history gets murky and they can't confirm a cascade, but a trial of deprescribing can still help. Now, there are many resources to support deprescribing. This slide has some of ours from deprescribing.org. We have 5 guidelines, and with a 6th one soon to be released. We also partnered internationally on one for opioids and have another one forthcoming for antihypertensives. Key is that because guidelines are only useful if people actually use them, we've got tons of supports for health professionals and the public, all available for free online. Now, I was asked to mention medstopper.com, which is a free place where anyone can go to help generate a personalized deprescribing plan for them, and then bring it to their healthcare team to start the conversation. And if you're a fellow Canadian logged in, I'll also shout out MedSafer, which is a great tool for the public supported by Health Canada. Lastly, there are networks that support deprescribing. The US and the Canadian network URLs are listed on this slide. And as part of the Canadian group, I can say we're constantly putting out new resources for the public and health professionals. So check these out. In closing, in keeping with ADE Awareness Day, I want to offer you 3 takeaways. One is prescribing cascades result from adverse drug reactions when we use a medication to treat the side effect of another one. Sometimes cascades make sense and are appropriate, but often they aren't. Second, to help identify and prevent cascades, ask, could this sign, symptom, or medical condition be caused by one of my medicines? Third, deprescribing has many benefits, one of them being that it's a strategy that can help investigate and manage cascades. So if I've made you excited about cascades or deprescribing, my contact info is on this slide. Thanks for the chance to be here today.
All right. Again, what an awesome lineup of speakers we've had today. We wanted to use some of the remaining time that we have to field some questions from the audience that have come in, and let's jump right in. Let's see
So
here.
real quick, we have one more short presentation.
Perfect.
Jacob Alcall. Jacob's a PharmD candidate from Texas Tech University and Chief Operating Officer.
Hey everyone. So today we wanted to take a moment to discuss how you can get involved. Really, whether you're a healthcare provider, patient, advocate, anyone on the spectrum, this is really a joint effort. And so I'll share my screen here, kind of highlighting just the theme of what we have going on here. So let me do that. So how you can get involved. Really, the picture here, it's a marathon and car events that we're hosting. The theme is the race against adverse drug events. And if you saw the LinkedIn post today from the American Society of Pharmacovigilance, which we'll put the link onto the LinkedIn page if you aren't following, but it's very important to stay in touch with sort of the news and the coming data that's emerging. And so, we've seen hashtag fourth cause. We've heard that adverse drug events, unfortunately, are the 4th leading cause of death in the US. And that number is north of 50 million or close to it. There are a lot of unknown cases that aren't documented as well. So that number could very well be much higher. But the idea is we're trying to prevent it from becoming the 3rd leading cause of death. And so, we don't want to transition to that. That's why it's very important to get involved now, bring awareness now. And so we'll start off with, we're happy to announce this year we're launching our very first marathon. You can choose to run either run or walk, or whatever support that you can give with a 3 or 4K. And the idea is, this would be the first among many that we would host across the nation. Although I know a lot of you aren't in New York, this is a way where, we can partner with individuals to bring awareness across the nation, across the globe. And so this is with the Manhattan Run Club and Brooks Running, and we're happy to establish that initial partnership. Now, the next way that we think we can sort of engage or empower this sort of race against adverse drug events, it's really in cars. And so, in Texas, there are a lot of racetracks, and there's a lot of events that go on with vehicles. Charlotte, North Carolina is the home of NASCAR. And so what better way to support this really um, you know uh, incredible uh, journey with racing with these professionals and these car enthusiasts, and really anyone that uh, can put a sticker on their vehicles, whether their windshield or bumper, uh, sort of like a bumper sticker. These are things that we're happy that we can go ahead and launch onto our website, where you can go and obtain one and show your support for fighting this adversity, this adverse drug events. And so that's something we're also launching this for this year. Please stay updated on the LinkedIn and Facebook and Instagram page with a lot of those updates. And we're looking forward to collaborating with each and every one of you. And now the next thing I want to get into is, well, a lot of us want to fight with this cause and show our enthusiasm. This was just a snippet of some of the individuals who have posted, who have been victimized or have loved ones that are victims of hashtag fourth cause. And we want you all to know that whether it's someone that you know or you personally can speak up, we want you to know that your voice is heard. And we encourage each and every one of you to post on LinkedIn that you attended this event, and we will send out an attendee banner after this webinar, where you can go ahead and showcase that support. Um, uh, but not even just for us, even our fluffy friends too. They are also victims of this as well, and we can't forget that. So awareness is a spectrum, and we want to go ahead and embrace each and every one of those. We discussed a lot of resources today. Sarah and the team will go ahead and we'll make sure that all of those resources are disseminated to each and every one of you, so that we can make sure nothing is missed. Thank you very much for all of your support and for attending this, and I'll hand it back off to Ben to do a moderated Q&A.
Jacob, thanks, and thanks again for all your work behind the scenes and helping us to prepare and put on this event today. Very much appreciated. Now let's transition to some questions we've received from some of the attendees today, and we'll read them off, and then our panelists can jump right in. First one we got here, from a systems perspective, ladies and gentlemen, what do you see as the biggest obstacles preventing us from reducing ADEs effectively? Are there any specific, maybe policy or clinical gaps that stick out or that you've observed that need immediate attention?
That's a great question that goes right to the reason for the Right Drug Dose Now Act of 2025 that was just reintroduced today by Swalwell and Crenshaw. There are a number of publications out there on widespread barriers to addressing adverse drug events, but one of the things that I mentioned, we have not updated the way that we track them since we use the cassette tape as our main music format. So the Right Drug Dose Now Act calls for an update to the National Adverse Drug Event Prevention Plan to incorporate pharmacogenomics. It calls for an update to make it easier to report adverse drug events in the system. It calls for updates to Technology, so electronic health records that our doctors use, e-prescribing tools to flag for appropriate testing, as well as move beyond just drug-drug to also flag for drug-gene and multi-factor interactions. Certainly won't solve it on its own, but this is a very good step in the right direction. Again, would encourage everybody to go to fourthcause.org/RightAct and learn more about how they can support the efforts to address some of those systemic issues that we're aware of.
Ben, another consideration would be going prepared to see your doctor. So when you walk into your doctor, describing the symptoms that you have, making sure that you are exploring alternatives to drugs in the first place. So are you talking about your diet? Are you talking about exercise? Are you talking about allergies and what have you? Then if a drug is prescribed, to ask, what are the potential risks? And really ask for signature-based informed consent. Knowing what you're signing up for is a really important thing. Third, you might ask how you're going to monitor together any repercussions and what do you do if there is an adversity. And then finally, what might be an off-ramp to this drug? If it's a temporary situation and that you have some symptom that you hope is temporary, how am I going to get off this so it's not a drug for life? As the earlier speaker was talking about cascading, I have seen so many people, my elderly parents who have since passed away included, where it's just symptom upon symptom, creating drug upon drug, and they never take away. It's just an ever-growing cocktail. So I think going in informed and asking questions is going to be an important aspect. And then finally, how do you report an adversity if you have one?
Thank you, Michelle. Moving on, let's see, we had somebody here submit. Why is it so difficult to hold institutions accountable for medication-related harm? And what can be done to improve transparency and accountability?
You want me to take that one?
Teed it up for
There
you, Bob.
Go. There you go. Again, it's basically the journey that I've been on. Basically, is persistency. Again, it seems like I had followed all the steps in regards to in regards to getting accountability of what happened to me, and all the systems had failed me. And that's one of the missions I'm on right now, is to, again, make sure this doesn't happen to any individual or family that suffers something like this. I wish the doctor and Johnson & Johnson had assigned an independent medical evaluator to step in and into my case and find out what had taken place at this adverse event, and find out who was at fault. And we're going back 21 years later, but it's I feel like and you can see in the documentary film there's a section that I did called Litany of Indifference that goes over what had gone wrong. I mean, people say I'm the Andy Dufresne of the medical industry, as far as the Schwartzshank redemption here, as far as what had taken place that had happened to me. But I hope that we move down with better informed consent, signature-based informed consent, and again, organizations like yours that is educating about medicating is going to bring more awareness.
Michelle or Christine, any observations or thoughts on that question?
I'll tell you this, there's an awful lot of work being done. In fact, we know on the MAHA team itself, there are a lot of people contributing. For example, there's a fellow named John Spagnola, who's the president of Veteran Support Services, who has gotten great energy around signature-based informed consent for the military, for veterans in particular. And there's legislation that's being introduced to firm that up. Again, I would go to the book I mentioned earlier, The Parental Rights. So many parents are really being pushed into by the schools, pushed into ADHD, depression, anxiety, and gender dysphoria, drugs that certainly have potential risks. And knowing your rights is going to be an important component for them as well.
Christine, this one's for you. So pharmacogenomic testing has the potential to significantly reduce ADEs, yet uptake still remains slow. What are the key barriers preventing widespread adoption, and how can we overcome them?
Yeah. I think that I did point to resources at uscript.com/talk to doctor, TALKTODR. There is a list there of medications that are impacted by genetics, and this is according to the FDA or CPIC. CPIC is the guidelines body for pharmacogenetics. They use a vetted process to look at all of the evidence and determine if we should be changing drugs or doses based on pharmacogenetic information. And these are very commonly prescribed medications. I would encourage everybody to take a look at that list and share that list with their healthcare providers, especially if they're going to be taking one of the medications on that list or they're already having issues. I noticed when we saw the screenshot from Jacob of the people that had put in that they had had adverse drug events and had the signs up, you may have noticed a lot of those were women. Women are almost twice as likely to have adverse drug events as men because most of the generic drugs we get pushed to were approved predominantly in males of European ancestry. We also see a lot of pediatric impact. So I'd say step one, CPIC is a great resource. The FDA is a great resource. Take a look at that list and be prepared to talk to your doctors. They didn't learn this in school. Part of the Right Drug Dose Now Act is to educate healthcare providers, specialists, primary care physicians, nurses, pharmacists. This just isn't something that people were taught. So we need to advocate for ourselves, just as we need to advocate for not getting a prescription if we could just be exercising.
One last question. We'll kind of make this like a lightning round for each of the panelists that we had today. So just think about this. In one sentence or less, if you could implement one immediate change, whether in clinical practice, regulation, or public awareness to reduce ADEs, what would it be? We'll use this to close it out today.
I think it's going to be a lot of the practices that Maha is already talking about, that getting rid of advertising on television and preparing people to properly meet with their doctors and I think a lot of the cascading practices that were spoken about earlier.
I would mandate clinical decision support upgrades that take not just drug-drug, but drug-gene and multi-factor interactions into account. We've had better technology to manage medication risk for decades, and it's not being used because it's not a priority.
I would go with the basic regulations. The financial industry has so much regulations into delivering a return on investment. We need to create something of this nature in regards to healthcare and medication where we have return on health, because without your health, you're not going to be able to enjoy your return on investment. And I think we have to measure that, especially when it comes to our children. Thank you.
For mine, I'm going to go right to the front line, to the patient. What can you do for yourself? 2 questions. Do I still need this medication that you're giving me? And second, could this thing I'm experiencing be caused by one of my medicines?
We're coming up on the top of the hour, and as a co-host of the event today with my partner, Sarah, we just wanted to say thank you very much again for taking time out of your busy week to roll up your sleeves and not only help champion the 4th year of National Adverse Drug Event Awareness Day, but reflect on this last hour. And even if it's only one thing, hopefully you're leaving today learning something new, changing the way you think, about adverse drug events, and motivated to take action in whatever part of the ecosystem of precision medicine you live, breathe, or find a way to get involved. So with that, thank you very much for your time from everybody at the team of ASP, and have a great rest of your week. We look forward to seeing or getting in touch with you soon. Thank you very much.